Hello, everyone. I'm Ira Pasternack, president of Web for Doctors, and I'd like to welcome you to our interview series about the business of occupational medicine. In today's interview, or in this interview, we have Dr. Larry Earl from the National Association of Occupational Health Professionals, or NAOHP. It's only appropriate that Dr. Earl is our introductory guest because he was my actual introduction to the fields of OCMED and urgent care. Also, when I built a website for the practice that he owned back in 1999. But in this interview, we'll hear about his journey and how it started a decade or two before then, as he found his way into the field and went from there to being a practice owner to now being a consultant and head of the NAOHP membership organization, which, if you're not already a member, we highly recommend for all OCMED practices. If you have any questions or thoughts, please comment below the video. Now, enjoy and be inspired. All right. Well, we are here today with Dr. Larry Earl from the National Association of Occupational Health Professionals, NAOHP. And would like to welcome Larry to be the first interviewee on our new Web for Doctors interview series about the business of occupational medicine. Welcome, Larry.
Such an honor. Thank you for having me.
You are quite welcome, and you are an appropriate first guest, of course, for this, since it was a little over a quarter century, 25 years ago, that we met, and I built my first website for an urgent care and occupational medicine practice. So that was how I found my way into this world of urgent care and OCMED. But why don't you tell us, Larry, how did you actually first get involved in occupational medicine?
Sure. Yeah. It was when I first went into urgent care practice back 40 years ago. So even before then, 1984, into my first urgent care practice in the Seattle, Washington area. And even in that very first practice in urgent care, I was exposed to the Washington L&I, Laborers in Industry program, and started seeing injured workers through that urgent care practice. And I just remember that they did what I thought was a really good job at educating physicians about things like return to work strategies and how to write modified duty prescriptions. And, really, even for physicians who had never done that before, I think for me in that position, they made it relatively easy, and I enjoyed taking care of those patients. And then later on, when I moved to New Jersey and worked as a staff physician at the IMCC, the Immediate Medical Care Center in Chester, the owner, medical director there, asked me to take on the role of the OCMED expert for that practice, even though it wasn't heavily occupational medicine. It was mostly a residential practice, but we had enough clients that somebody really needed to know what they were doing. So he asked me, and it wasn't really on my radar at the time, although I did enjoy caring for those injured workers previously. So I did it. I just went out and learned everything that I possibly could from ACOM and SEEK and other types of conferences that were all related to work comp and OCMED. And over the years, just grew to love it.
Great. So you actually just answered my next question for you pretty much, which was kind of how did you first get involved, but why did you stay? So it was kind of happenstance and to a certain degree, but then as you got the exposure to working with those, not just the patients, but those employer clients, there's just something kind of unique about that in medicine, huh?
Well, it really grew from there because, when I sort of graduated from being a staff physician and moved out of those roles to become a corporate medical director for a company called HealthNet Medical Group in New Jersey, we had started with 6 urgent care centers there, and it was expanding. And one of the new clinics that we started was 100% OCMED for the city of Jersey City workers and the Hudson County employees. So I also worked some shifts there. So I was corporate medical director for the company, but also worked shifts in the Occ clinic. And, it was interesting because that was one, as New Jersey is an employer directed state, right? I think we're going to talk about some state issues. It involved setting up one of the first workers' comp PPO panels in the state to serve those employees. So I was focused early on in finding and collaborating with specialists and PTs and other folks that were well attuned to the needs of both patients and employers.
Hmm.
So then when I left there and became the owner of IMCC in Parsippany, where we met,
Right.
3 or 4 years later, that was probably 70% Ahmed. And then I got much more into the relationships with other employers of all sizes. Did on-site clinics, became fully versed in Ahmed services, did the DOT clinics all over the state. So we had 5 of those. So learned all about commercial driver and the regulations and training our other docs and PAs to do all that stuff. So it just kept kind of finding me and pushing me more into all things Ahmed.
Yeah. So there at IMCC, as you sort of took on all that more full spectrum of the services of a full Ahmed practice, you really started treating it more as a business. And I know that since that's kind of back in the days when we first met, and we treated it as a business together as far as how we work to reach out to new um,
Yeah, yeah,
employers in the
exactly. So before it had been all those urgent cares, and we did, I think mostly workers' comp was where the focus was from the urgent care perspective. But
Mhm.
moving to IMCC, we got much more into also the other types of Ahmed services, the exams, the regulated exams, the on-site clinics, a lot of those things that are really more fully Ahmed practice.
Sure. So some of the more complicated things, also some of the more profitable exams, if you know how to do them and can get them.
Yeah, the regulated exams, firefighter exams, hazmat, all that kind of stuff. Sure.
Okay. Um, the Tell us about some of the challenges that an Ahmed practice faces, or maybe even tell it from the perspective of an urgent care practice that is considering occupational medicine. What are some of the challenges that they face from a business perspective?
Sure. And I can speak to this from both personal experience, having run these things for so many years, and the last decade, as a consultant for all manner of urgent cares, Ahmed clinics, large health systems, large and small community hospitals. So I kind of seen a lot of different challenges in either starting practices, starting the Ahmed portion of the practice, the whole urgent care practice, challenges with those that maybe are not performing well, or how do they staff. So I think I think the main challenges fall into several different areas. One is just understanding what the market is. So you said, like a new urgent care that wants to get into the Ahmed world. How do they even start? How do they know what the market looks like? So analyzing the market, they often have never done the market research to learn how many employers and employees are in the market, are in their area, what industries are they in, what's the competition like, what would their predicted market share look like, what kind of volume of the different types of services should they be expecting to bring in, what does the dollar amount of those services look like. So I think you want to, number one challenge is just understand, if you want to get into that business, what is that business, what does it look like.
Yep.
And then I think another area that's very challenging all the time, but even more so these last couple of years, is staffing, right? Everybody's got issues with staffing, competing for docs and nurse practitioners, often coming from different fields, right? Because you just can't find just Ahmed trained docs to do this. They're not out there, they're not available.
Mhm.
Um, so you have to find folks that are interested in doing occupational medicine, probably coming from different fields, competing for those nurse practitioners that are often, helping on the front lines, and then training those folks to be competent in all things Occ because they weren't trained in whatever field they came from. And it's its own animal, right? It's not the same as family medicine or so many other fields.
Yep.
Staying up to date on the myriad regulatory issues, OSHA regs, DOT, CDL, NRCME issues with commercial drivers, things like managing and balancing the medical records and confidentiality with employers. Employers need to know certain things, but they shouldn't know other PHI type things. That's always a challenge. And I think finally, what we're seeing really is learning how to integrate more comprehensive, what we call total person health concepts into the typical core OCMED service lines, which is really, has many facets to it. One is the Corporate Accountability Act, which a lot of people don't even know about, and that's where companies must have a fiduciary responsibility for their healthcare costs. So they have to be looking at where are the dollars going? Is it effective? Are they paying for care that is truly um, providing outcomes in their employees? And so, I think occupational medicine practices really need to start looking at that and learning how to do it and helping their employer clients do more than just take care of pre-placement physicals and work comp cases.
Got it. So kind of talking about work comp cases, that is one of the areas where we're going to, of course, see the most differences from state to state. So talk for a few minutes about the challenges or the different scenarios that practices are in, depending on whether they are in an employer choice state, like we mentioned New Jersey was,
Sure, yeah.
or an employee choice state, like just over the border in New York
Right.
is, or that happy medium, which is some sort of a panel state, which really, I don't know that there's any two states that have a panel model where the model where it's exactly the same, but the general model of having a limited panel rather than full choice.
Yeah, I think you're right, and I think you really just described the three kind of different scenarios that you can find in work comp, and I think you're right when you say state variations are really related mostly to work comp. The other core services, I call them core services, drug testing, other types of testing, and the other types of work-related exams really don't vary very much, state to state. Many of those um, federally regulated, right, by OSHA and other regulatory bodies, so they're pretty much the same.
What
There
about,
might be some state variations in
are there
those,
a
like
few states that maybe have some harsher state
yeah,
OSHA
like
regulations,
California.
but
Exactly, yeah, California
that's
kinda
limited
leads,
because
like,
they have
in
more states at this point?
lead and silicosis and some of the things that they might be a little more strict on. Um, But yeah, for work comp, as you said, some states are employer directed. New Jersey is a good example for me because I spent, 27 years practicing there. Um, so that as an employer is easier, right? You can pretty much pick the provider that you like. It may not always be the best for the patient. So if you're in that kind of a state as a provider, I think you really have to, I think your challenge is really not being perceived as the evil company doctor, right? You really always first job is to take great care of the patient. I don't care what state you're in or who you work for, or who pays the bills. Our primary responsibility is to make patients as well as we can, right? That's what
Yep.
we're physicians for. And so I think you have to overcome that potential perception from patients that you're working for the company and you don't have my best interest at heart. And that's just part of the art that we have to balance when we're in an employer directed state, I think.
Mhm.
And then patient choice is really a very different challenge because you have to really promote to those patients that you're the good choice because you have the expertise in making patients well from a work-related injury, and that you do have their interests at heart in terms of getting them back on the field, right? If they injured themselves playing softball, they'd want to get on the field as soon as they could. And if
Mhm.
they injure themselves as a worker, they don't want to lose their income, right? So they
Right.
still want to get back on the field per se, and you're really the best one to help them do that. So I think you have to approach your marketing and your communication with patients differently depending on what state you are in and what the regulation is. And then you're right, there are many that are hybrid where they have a panel, maybe a state like Tennessee, for instance, you have to give the workers at least three physicians.
If you don't fill out your panel correctly, it becomes an employee choice state, essentially.
Right. Yeah. So if you don't, you have to give either a full panel or a certain number of choices to the physician, to the patient, and they can start there. And oftentimes they can then go and choose some other physician if they're not happy with that. So yeah, all the states have different rules about that, and you really have to go state by state to figure out, how to approach that.
So, in the states where you are dealing with a panel or even employee choice, are there any things that the employer can still do to influence that decision sometimes?
Well, yeah, like I said, I think the employer has to convey to the staff, to their employees that, look, we've picked this panel of physicians because we're confident in their abilities to do just what I said, to make you better faster and to really attend to your needs and make sure we're doing everything possible, and they know how to work the system to get your testing done, your physical therapy, your claims out to the claims adjuster so you can get paid, and all those things that really should make it easier for the patient to work with this set of providers that knows the system, has a vested interest in both getting you better and helping the employer manage the case, so the communication is there and everybody benefits from it. That's the whole idea.
Great.
Yeah.
All right.
Then
Well,
I think some other state differences, I just wanted to mention other things that are different state by state, not just workers' comp,
mhm.
but staffing. Like, yeah, MAs, for instance, are
How
a
much
big part of
different
our
people can
practices
do at
now.
different levels?
Yeah, they have different, MAs have a very different scope depending on what state they're in. In some states, they can't really do anything except vitals and rooming patients.
Mhm,
Other states, they can be certified to do venipuncture.
mhm.
They can give injections. There are some states where they can even obtain a limited X-ray license. We have a horrible time finding X-ray techs in urgent care and OCMED practices. Well, some of those states, the MAs can go and get a limited X-ray license to do just the kinds of X-rays they need to do in those clinics. Um,
That's
so,
sort of both a
MAs
challenge
is one
and an
area.
opportunity for the industry that you can get creative staffing to deal with 2024 problems.
Correct. Yeah, correct. And the other big areas that vary state by state are with the APPs, the PAs and the nurse practitioners. So PAs, often the scope again varies. There may be limitations on if they're even allowed to submit a first report of injury, or does that have to be done by the physician, and then the PA may do a follow-up. And they may not be able to do the first exam or the first report. They
Yep.
may not be able to determine causation. Sometimes only a physician can do that. Um, the number of PAs varies state by state that can be supervised by one physician. Some states have no limits on that. Other states, you can only have 4 PAs under a doc, or different numbers, again, depending on the state. For nurse practitioners, I think there are some similar scope limitations, mostly in terms of which states are now independent practice states where NPs do not have to have a collaborating physician versus some states where they still do.
They still do need that supervisor.
Yeah, but they might still have, like, again, I'll use the example of Tennessee because I just did a consult there. Same thing with nurse practitioners. The physician must do the initial report of injury and determine causation. The NP or the PA cannot do that in certain states.
Got it.
So those are, I think those are among the top kind of state by state issues that we tend to run into often.
All right. Let's see. We're going a little bit long here, but this has been some great information. Give us one opportunity that you see that the occupational medicine industry has to grow, for practices across the industry to grow.
Yeah. I wanted to give you three, so I'll just mention them quickly. Okay.
Give me the quick three, and we'll maybe have a follow-up.
Yeah, real quick three. One is digital transformation, right? AI is doing everything, but in both urgent care and many areas of medical practice, I think it's going to help us sort of stick to best practice protocols, I think is the area where I see it helping the most in kind of, using what the best practices are out there and guiding our treatment plans to be more concordant with those best practices. Second thing is biopsychosocial aspects of care, something that's been ignored for forever. And more recently, I think it's becoming quite evident how injured workers, but also for prevention, how things like mental health, financial stress, access to transportation, and many other non-medical determinants affect outcomes and delayed recovery. So that's going to be paid more attention to. And then total person health initiatives, using analytics.
Yeah, that's what I thought would be your one.
What's that?
If I had to pick one that I guessed your one would be total person health.
Yeah. So well, that's what I'm landing on at the end here. And I think, again, using analytics, we talked about, AI, but all types of analytics as described to really identify healthcare risks in those employer client populations, developing strategic interventions that help to mitigate those risks, and really just creating happier, healthier, more productive workforces is where we need to go with that.
Great. All right. Well, before we wrap up, Larry, tell us a little bit about NAOHP and what, both as a membership organization and as a consulting organization, kind of what you offer the community.
Yeah. So NAOHP has been around, I guess, almost as long as I have, about 35 years. And, members today enjoy many resources through their member dashboard right on our website. We have hundreds of articles, videos, from free courses to archived town halls where we talk about every conceivable OCMED topic. There's discounts on courses, manuals, guides, policies and procedure manuals for everything. We have a member forum to exchange ideas and problems with other members. The member directory, where members can reach out to other members for any number of reasons. And we're transitioning that now. One of our kind of new initiatives is transitioning that member directory to our OC market. We call it the OC marketplace, right? A place where employers can now meet our members directly and start to get their services performed through that marketplace. We have a free job board, and just joining a real community of helpful folks that all have the same goals and frustrations, and where the organization itself is focused on helping them manage the practice day to day. It's not clinical content. It's not just clinical content, although we have that. You can get that in a lot of places. But there's really nowhere else that focuses as we do on how do you just get through managing this practice and dealing with employer issues and making that communication the best it can be and taking care of both patients and employers at the same time. And then our other services, you mentioned, we have our annual conference coming up in Milwaukee this October 20 to 22. It's always a great place to network and, again, meet like folks and learn, again, everything from administrative aspects to clinical aspects of the practice for both newbies and seasoned veterans alike. We have consulting programs where we can help a startup to again, seasoned practices that maybe are not performing optimally. We work with a lot of hospitals that wonder, well, we have this OCMED program. Why does it never make any money? Does it not pull in the right employers and all those sorts of things? So full consulting programs, online training for sales folks, for providers, for administrators, and our new marketplace, as I said, is something we're really excited about. That'll be launching in the next couple months.
Great. Well, I can certainly attest that since back when you were still in your IMCC days, we were exhibiting at NAOHP, and certainly the community that we have found at that conference and at the related online and offline events has been tremendous. So highly recommend to anyone listening that is not currently a member that you go check out NAOHP.
Thank you very much.
Oh, well, thank you very much,
Appreciate
Larry.
that.
It was great to have you on to interview to kick off our series. And
Yeah, you know what? And thinking of interviews, I forgot to mention one other thing.
oh,
We have our new podcast, our Fit for
yes,
Duty podcast, which you can also find on the website, and there are several episodes there. So please tune into that as well. Goes right
all
along
right,
with your platform here.
excellent. Well, we will make sure to link to your podcast and your website in the notes to the recording here, and we'll see you soon.